Hello, everyone. Welcome to another Saturday session. Today, we are really happy to have the program of our dear friend from the Academy, Abir. And we today have a pleasure to receive Willis Kington Health. And we are really happy that you all are joining us. And I will pass the mic for you guys to introduce and say hello.
Okay, I can start. Okay, hello everyone. My name is Abir. I am an international medical graduate from Palestine, and also I've been a member of the CB Solvers Academy for almost 1 year. And in June last year, I joined my internal medicine residency program, Knighton residency program. And yeah, I'm excited for this session. I'm excited for seeing both of my residency program and my second family discussing medicine together.
Okay, and I can go next. Hi, my name is Parinushtha. I'm an IMG from India. I'm from Osmania Medical College, which is in the south of India. I joined Willis Knighton to train in June of this year. I'm Abir's colleague. In my spare time, I like to read books and listen to music. And one fun fact about myself is that I'm in the top 1% of Spotify listeners. Just saying. Okay, handing over to you.
Hey everyone, good morning, afternoon, or evening, wherever you are. I'm Kashisha. I'm also one of the PGY1s at Willis Knighton Health System, co-resident of Abir and Parnishta. I grew up in a town in Western India called Ahmedabad. I did my medical schooling from BG Medical College, which is also in Ahmedabad, and then I moved to United States for my residency. Fun thing about me is I like movies a lot. I literally have a 2 terabyte hard drive full of movies. You can find me in cinema hall if I'm not at home or at work. And I love watching sports, be it football, be it soccer, NFL. I just am very into sports, and that's about it.
Okay, I guess I'll go last. My name is Vivek Murthy. I'm currently a third-year resident and a chief resident here at Willis Knighton, and I'm very happy to be here. And we have an excellent group of interns here. So about the fun thing that I've been up to lately, I've been going to Jiu-Jitsu, which is a martial art, for the last couple of months, and I enjoy it a lot.
Oh, nice. A lot of cool fun facts. Thank you all for sharing with us. I think we can have the whiteboard. Raul, thank you so much for scribing. And we are going to have the case discussions, Ravi and Johan.
All right, I'll just say hi quickly. So, hi everyone, I'm Johan. I'm an AMG from Cameroon, currently based in Barcelona, and I'm so excited to discuss this case. And I'm just waiting for you to start. And hi everyone, thank you for tuning in on a Saturday. So, yeah, that's me.
And I'll chime in. Glad to be backing up Johan. Definitely a fan of Abir for the years that she's been with us at CPS, and glad to be here and to learn more about your program, and also supporting my NFL team, the Ravens in Baltimore. Yeah. So I know Mohan is a NFL fan. So I'm currently a program director at Sinai Hospital in Baltimore. And should we get going?
Whenever you are ready, we can start. You ready? Okay. So you are ready, guys?
Yes,
okay.
You can start. Thank you.
Okay, so we will gonna have 4 aliquots before revealing the final diagnosis. So today's patient is a 74-year-old male patient presented to the office with the concerns of weight loss over the past 6 months. And I will gonna pause here.
What do you think, Johan?
Well, that's really interesting. So I mean, when I see a chief complaint, I look at specific things. First, the time frame. 6 months, I will call it chronic. Second question is why now? Why the patient is presenting now? Is it because it's slowly progressing and getting worse? Or is there a sudden change where, I mean, it's just crumbling all of a sudden, just like when the pen fall down? So it's stable and then we have a huge change that pushes the patient to come. And weight loss over 6 months is never a really good sign, even though we still have to quantify the weight loss to see how bad it is. But weight loss suggests for me inflammation. So it's not necessarily a good sign, but overall I need more information from the HPI to basically understand more the weight loss, but anything that can lead to inflammation like malignancy can definitely lead to weight loss.
Absolutely, Johan. I think to jump into a spot diagnosis is very early in the game, but I like this sort of 10,000 foot view. When we think about weight loss, what kind of conditions do we think about? So is it intentional, unintentional would be the first question. If somebody's on maybe a medication for weight loss, somebody has had surgery, or somebody is trying to lose weight, in that case, that's a whole different game. But in this case, this is unintentional. And the way I think about it, 3 main buckets. I won't really elaborate on them, but first thing will be, is this patient facing a malnutritional state? I don't know if I'm saying it right. So malnutrition would be one. Second would be, is there a malabsorption state? Third would be a catabolic state. And catabolic is the large group where inflammation, infection, malignancy, autoimmune disorders, and other chronic medical conditions. So you have to see what may actually, in the past medical history, what could be causing this, such as a diagnosis of HIV, such as a chronic diagnosis of liver cirrhosis, synonymous with wasting in patients, and then also CKD and things like that. So basically, 3 things. Is this a hypercatabolic state? Is this a malabsorption state? Is this a malnourished state? And also you have to put a subcategory in if there's a lack of access to nutrition, if the patient isn't having some issues where they're not able to gain appropriate access to food. So I'll kind of stop there and we'll get more information. Any other thoughts come to mind, Johan?
No, I completely agree with you. I think, when we have these buckets, now we need more information in the HPI and the past medical history to basically start ruling out things.
Absolutely. We can go with the next alcohol.
Abir, I think we can't hear you.
Okay, I'm sorry. Okay, so for HPI, a 74-year-old white male patient with a history of well-controlled HIV, diagnosed 44 years ago, non-Hodgkin lymphoma, diagnosed 20 years ago in remission, prostate cancer, diagnosed 17 years ago in remission, and mild dementia. He's being followed up regularly with hemato-oncology. He reports unexplained weight loss of approximately 25 pounds over the past 6 months. The weight loss is unintentional, and he's unsure of the cause. Despite getting adequate rest, he described feeling tired throughout the day, and he noticed like a significant increase in fatigue during this time. And the fatigue has been progressively affecting his ability to carry out normal daily activities. He denies experiencing any other constitutional symptoms such as fever, chills, or night sweat. And for review of system, it's only positive for weight loss and fatigue, no fever, chills, or night sweat, no shortness of breath, chest pain, edema, orthopnea, paroxysmal nocturnal dyspnea, no cough, sputum, hemoptysis, or wheezing, no nausea, vomiting, diarrhea, abdominal pain, or a change in appetite. For past medical history, he's an HIV patient, well-controlled, non-Hodgkin lymphoma in remission, prostate cancer in remission, hypertension, well-controlled, chemotherapy-induced non-ischemic cardiomyopathy, and he underwent a pacemaker placement, AFib, hypothyroidism, anemia of CKD, mild dementia, And also worth to mention that 1 year ago, the patient underwent a colonoscopy, and during the procedure, a polypectomy was performed, and the resected polyp was diagnosed as a tubular adenoma. For medication, he's been taking dabigatran for AFib, lopinavir, ritonavir, and imitricitabine for HIV, atorvastatin, digoxin, Entresto, carvedilol, levothyroxine, and iron supplements. For social history, he's a chronic active smoker, 50-pack year history, 1 pack per day, lives with his family, no significant social history, no recent travel history, and family history is irrelevant here. Allergies, no drug or food allergies, and I will gonna stop here.
Okay, great presentation of the next aliquot Abir. And great case so far. So exemplifies the level of or standard of teaching at your hospital. So it's very interesting at this point. I just want to clarify, it's this history is non-Hodgkin's, not Hodgkin's, right?
Non-Hodgkin.
Okay, so I'll start off with this aliquot, Johan. So we previously hypothesized 3 different buckets for weight loss, and I think now we can sort of pivot towards the catabolic state. So we have 2 conditions here, which we sort of hypothesized about, which are the HIV category, so chronic infectious disease, and also malignancy here, which is the big one. So at this point, when trying to think about non-Hodgkin's lymphoma, I sort of think about the epidemiology. You usually have a peak, which is in the 50-year category. So this patient, 74 years of age, is in that age range for this diagnosis. And usually the etiology, HIV is an immunosuppressive disorder, right? And immune cells tend to stand guard. So they always tell you proper nourishment, proper sleep, your immune system is at peak and guards against these potential nefarious cells that turn malignant. However, HIV, because it causes immunosuppression, malignancies tend to occur hand in hand with these conditions, one of which is non-Hodgkin's lymphoma. EBV also can do this, HTLV and a few other disorders. The types that we usually think about, B cell associated or T cell associated, and then we have to think about, is this a condition which is within the node or extranodal as well? And then the history before, if this patient has had, is this an active disorder, or if this is currently suppressed? So we have to think about conditions where it can get really worse. So you can have non-Hodgkin's lymphoma become a leukemic phase, and then you can also have this rampant extranodal disease that can happen. So we don't know if we're dealing with this, if a condition associated with non-Hodgkin's lymphoma, or maybe a chronic complication of HIV, numerous sorts of opportunistic infections at this point. So definitely, you're right, there is inflammation somewhere, which is turned on. I'm not sure if it's actually the Hodgkin's lymphoma, or is it associated inflammation with that, or the HIV, or if there's a new malignancy as well. We've had numerous cases on CPS where somebody comes in with a chronic viral infection and has malignancy background and then develops a new malignancy. So there's numerous other, like primary CNS lymphoma, other malignancies that could be associated with HIV. So we sort of opened the door to many different hypotheses. I'm not quite sure at this point. I haven't sort of glanced at the screen to see, but I'll let you sort of cycle this in your brain and see what else you can come up with. Over to you, Johan.
Thank you so much, Dr. Ravi. I completely agree. I'll just add that, for example, I will first think about having a CD4 count, and I'll also lean a lot on the CBC and the physical exam to gain more information about his HIV and also the current hematologic malignancies the patient has in remission, non-Hodgkin lymphoma. And thinking about all that, he's not immune to other conditions. He's not immune to complication of his HIV treatment as well. So I'll say for now, I will go on and do a good physical exam and palpate the nodes as well and see if there's any change, and wait for the CBC and the CD4 count.
Just going back to just, I think that's a great start for the workup to decipher what exactly is the HIV. I mean, the patient's on heart therapy, so the patient has a suppressed viral load. Do they have a good CD4 count? So that definitely is important to start off with. And I think then also getting history regarding the non-Hodgkin's lymphoma. So, was this, I don't see if this was, there's numerous types, right? You have the aggressive, you have the indolent. We've had a couple of cases there where we go through. The one that I'm really fearful of, and I've had patients with this, is the diffuse large B cell lymphoma, which is the more aggressive type. So the types of aggressive ones, you have that, you have Burkitt cell lymphoma, you have mantle cell lymphoma, which are very more aggressive. The other types, usually like you have follicular, you have mantle cell, you have CLL associated small lymphocytic lymphoma and marginal cell maltoma. Those tend to be more indolent and take time to progress. So if unlikely aggressive, because that would have, the patient actually wouldn't be at this age and present like this, and patients usually suffer consequences pretty quickly with that. So I don't know if we're dealing with more indolent type. The T cell types usually associated with HTLV, if I remember. Anything else comes to mind, Johan?
Well, the only thing I want to add is, for now we're not. It can also be endocrine, for example. So there's so many things that can be present, regardless of his past medical history. And I think that, well, I mean, of course, for now we have to focus on the elements we have regarding this patient, but still, for example, endocrine and other condition can also lead to weight loss. So I think we'll have many more information with the CBC and the BMP. And yeah, so that's it.
Yeah, absolutely. I think also somebody in the chat mentions, B symptoms. Now, Abir mentioned there was no B symptoms. So I kind of would wonder, is without B symptoms, does this definitely rule out a complication of or progression of the non-Hodgkin's lymphoma? If it was positive, if Abir had mentioned there were B symptoms, I think then we pretty much could pivot to this domain. But at this point, less likely. But I think the labs, you had mentioned getting labs, starting off with the labs will definitely be helpful in doing a good physical exam, looking for node, any lymphadenopathy could also be helpful in this case, and also hepatosplenomegaly. Back to you, Abir.
Okay, so I can take over. As regards the vital signs, they were mostly within normal limits. The blood pressure was 122/73. The heart rate was 84 beats per minute. The respiratory rate was 16. The temperature was 98.7 degrees Fahrenheit, and he was saturating at 98% on room air. Coming to the physical examination, the general physical examination showed a patient that appeared fatigued and mildly ill appearing. The cardiovascular examination revealed a normal S1 and S2 regular heart rate and rhythm, no murmurs, rubs, or gallops. Lungs were clear to auscultation. Bilaterally, there were no crackles, wheezes, rales, or rhonchi. The abdomen was soft, non-tender, no guarding or rebound. Cranial nerve function was intact, normal sensation and motor function, and the reflexes were intact as well. The extremities, there was no cyanosis, no clubbing or edema. They had a normal range of motion, and there was no joint tenderness or deformities. And coming to the lymphadenopathy, there was no lymphadenopathy. So I'm going to pause here now. Does this change the differential any?
What do you think, Johan?
I mean, it doesn't really change the differential, but the fact that, as you said, I mean, there is no B symptoms, meaning no night sweat, and I'll say no lymphadenopathy as well. I mean, make me think that maybe it's not NHL. We shouldn't necessarily focus on that. But here again, we need the CBC to have more information. It can be a lot of other inflammatory condition. But for now, my differential is the same, but I'm betting less on an acute manifestation of his NHL for now based on the physical exam, but it's still on the differential.
Yeah, I agree. It's still there. And we sort of talked about, I'm interested in this indolent domain of non-Hodgkin or B-cell non-Hodgkin's lymphoma. And I think the chat is very active, and I'm absolutely siding with them. You can get lymphoma within the gut. So it's more hidden, and you may not have this diffuse extranodal disease. So lymphadenopathy doesn't extreme or just rule out this condition. But I would sort of pivot to now the HIV, definitely getting labs. So what if there's a infection that's manifesting this patient? So fever would be helpful, but again, we have to remind ourselves this patient is immunosuppressed. Patient is on medication, so they may not manifest with a fever, so that doesn't rule it out. Do we look for signs of sepsis? There's the tachycardia, hypotension. Is there hypoxemia, some signature in the lungs? Nothing there, nothing on the skin, malignancy on the skin, infection on the skin. Is there anything in the gut? The GI examination was negative. GU was negative. CNS, though, what's interesting, the patient does have the dementia. As we all know, from day one, HIV crosses the blood-brain barrier and starts manifesting with neurocognitive disorders, one of which is this HIV-associated neurodegeneration, HAND, they call it. One of my students presented this case to me, so it has stuck with me. So I like this designation of HAND. So at this point, is infection completely ruled out? I would say no. At this point, because the patient isn't like a regular patient, they're not going to manifest with the usual signs and symptoms that a patient that's immunocompetent would have at this point. What kind of infections? Again, I would look for infections that could be more hidden. Now, talking back about this non-Hodgkin's lymphoma in the gut, this marginal zone maltoma. So the mucosal associated lymphatic tissue could be a site where it could be hidden. And it's usually known, we all know about it, Helicobacter pylori, and its association with that. And you can also get this, people were talking about, or the chat, and Johan was also talking about the thyroid. It can actually manifest also within the thyroid, I think also within the orbits and several other places. But I'm just sort of throwing it out there, exploring a domain which is less likely. So let's bring it back at this point. Still, lymphoma is game, and also HIV is game. And I think the labs will shed light. I'm really interested in the CBC, looking for any sort of cytopenias, looking for any sort of also the HIV parameters, seeing how they are, and then taking it from there. Any other ideas, Johan, before we move forward?
I completely agree with your explanation, and overall, I'm just waiting for the CBC as well.
All right, I'm going to give you the lab results now. So the CBC showed a normal white count of 9.7 with a normal differential. The hemoglobin was 9.7, so anemia. Hematocrit was 28.8. The MCV was 109.8, and the platelet count was normal at 185. The chem panel showed a sodium of 141, a potassium of 4, a chloride of 104, a bicarb of 29, a BUN of 16, a creatinine of 1.27, a calcium of 9, a MAG of 2, a TSH of 1.6, a T4 of 4.6, and a normal T3. The LFTs were within normal limits. The iron profile showed an iron level of 68, a TIBC of 196, which was slightly low, an iron saturation of 35, a ferritin of 160. The B12 and folate levels were normal. The HIV viral load was undetectable, and the CD4 count was 374, and it had largely held stable up until that point. I'm going to pause here now.
Johan, what do you think?
Wow, that's really interesting. Wow, so regarding the CBC, I think we just have an anemia, macrocytic anemia with high MCV. Regarding the BMP, well, is the ferritin considered high? No, I don't think so. and the viral load is undetectable.
Yes.
Well, we had two big buckets before having the CBC and BMP. The first one was NHL, and the second one was infection since the patient has HIV, so a long-standing infection. So now regarding the two, with the CBC and BMP, I mean, it's hard to say the patient has an infection now, even though we will still do a viral panel. I'm sure they did a viral panel as well of other conditions, but it's hard to make a progress with that with this CBC and BMP. And regarding NHL, the patient is anemic, WBCs are normal. I mean, I agree with you when you said it can, still be in the gut, but still I'm not leaning toward that. So for now, I can hardly make any progress, but I'm not moving toward the two big buckets we were talking about. So I really need your help right now.
Oh, I think you're doing a splendid job. So it's interesting in this journey so far. You see the narrative that's being laid out here. I think at this juncture, Johan, what's going to really help us is to now walk backwards and kind of look again, do sort of like what I call a dragon eye fly view, look at the whole picture. And what our friends, our scribing friends have done for us is put everything in red, which is meaningful to this case. So fatigue, weight loss, there's no headache, there's no shortness of breath, there's no abdominal pain, there's nothing else at all. No fever, no chills, no B symptoms, nothing, just plain weight loss. So again, when we started out in this journey, we talked about the causes of weight loss, and I think we may have to sort of do a recalibration of this thought process. And I think again, catabolic state, right? And we thought about malignancy and something in the bowel. One thing that comes to mind, like HIV and bowel associated diseases, IBD kind of conditions, if there's something there. Then again, I would think about some abdominal pain or some symptoms. There's nothing here at all. So the patient isn't acutely ill, but the patient's having this condition, and there's something that's sort of chronic and I would say rather nefarious, but not acutely toxic in this patient. So you have to start thinking about these indolent conditions. Going through, so the CD4 count, I was looking for, what was the CD4 count again? It was 374. So it pretty much does just rule out a large number of different conditions that you have. So usually what I think about, if you have a CD4 count above 500, you're susceptible to all the sort of community-acquired conditions, CAP and so on. And then 374, I think, still allows you to be, somebody mentioned TB. TB can manifest in the bowel and can cause chronic inflammation, can be very indolent and slow growing. And I think abdominal CT, a CT will be helpful because it's something that's not apparent and coming to the surface. So with this very, very well done examination by our friends here, doesn't shed light on anything that could be causing this. If the CD4 count was less than 200, then we could then it's fair game. All the different kind of opportunistic affections come to mind, like PJP, but this patient doesn't have anything within the respiratory system. Fungal pneumonias, cryptococcal pneumonia, candida, and so on, toxo, CMV, cryptococcus, all these different conditions. MAI can also be fair game as well. But at this point, I think we pretty much can rule out these. TB still is of interest, and I definitely would look for some signature within the gastrointestinal system with a CT. Should we do a pan CT in this case? When you have no clue, nothing, no breadcrumbs are being laid out to follow, I think at this point maybe sometimes we just do a pan CT to see if there's something going on within this patient. Any other ideas spring to mind, Johan, before we move on with the next aliquot?
Another thing will be regarding the age and the sex of the patient. unfortunately, he doesn't have bone pain, but we have to, with the anemia and the somewhat elevated creatinine, we can still pay tribute to multiple myeloma and rule it out as well, because it's definitely possible since the calcium start increasing a bit later. So a CT will definitely show the specific bone lesion that we have in multiple myeloma anyway. So as you said, doing a PET CT will definitely help us narrow down the diagnosis and see what's going on, because we know that something is happening, of course, but for now it's so blurry. And even regarding the differential we had at first, it's really hard to make any progress. So definitely additional exam and imaging will help.
I think that's a splendid thought, thinking about multiple myeloma. We always teach CRAB, right? So there's other than CRAB diagnosis of multiple myeloma. If you do a bone marrow biopsy and there's greater than 65% plasma cells, you don't need CRAB for this diagnosis. There's other variants like the solitary plasmacytoma manifestation of a tumor somewhere, because multiple myeloma can manifest as pseudotumors, what we call it. So you still can have multiple myeloma, and then you wait a week and you repeat labs and you might see some of the signature of multiple myeloma, like the hypercalcemia and so on that you mentioned. So it's still not out of the picture, and I think that's a splendid job, splendid thought there. Anything else before we move on to the next aliquot?
No,
Okay.
I think that Abby enlighten us.
I'm sorry, go ahead, Johan.
No, you can go ahead.
Okay, so I completely agree with the reasoning over here, which is the same thing that we went through, because the vitals and physical exam did not really reveal much. And given his history of multiple malignancies, along with the only presenting symptom being weight loss, we thought the same thing. Maybe it's a recurrence. So let's get a pan CT. We did a chest, abdomen, pelvis, a complete pan CT. The abdomen pelvis findings were unremarkable, but the chest CT did show something. And let me just share it with you. So this is what we saw. Do you want to take a shot at what we're seeing over here?
Yeah, I think so. Johan, how are you with the CTs? Do you want to just kind of describe the abnormality that you're seeing?
So do you have only one picture?
I think you're muted.
We're going to start with this one picture. Yes, this is what we saw on the first imaging.
So just a disclaimer, I'm really not good with CT, but I will take a shot. So well, I just see a sort of mass close to the I think it's the right lung, near the mediastinum, and a part of it, I mean, right next to the heart in the right and the left lung, my bad. So a part of that, I don't see anything else.
Wonderful, wonderful point there, Johan. I think CTs, I think you need to look at a lot of them. That's why I kind of was like, take a stab at it and see, because you always learn. So even if you can identify the abnormality, you've done a wonderful job. And then later you elaborate on it by learning the nuances of CT reading. But I absolutely love images, and I really appreciate you bringing the image, because it really does help us to understand what's going on within this patient. Because again, on the exam, on HPI, there was no symptoms of any respiratory disorder, no chest pain, nothing that could shed light on what's going on within the patient's lungs. But here, you're right. There is so we're at a view where we're seeing maybe the beginnings of the heart. I do see some atherosclerosis within the aorta there below the diaphragm. I don't see the liver looks fine. I'm seeing the spleen, it looks fine. But then looking at the ribs, we're seeing parts of the ribs, but we're not getting the whole view. But I don't see any abnormalities there. But you're right, Johan, we're seeing on the right lung, we're seeing this little opacific process with some sort of branching off. So I don't know if that is the disorder. We definitely need to look at more images, but we also see this almost like the airway being highlighted. Sometimes that's in a pneumonia that's mentioned as an air bronchogram. Maybe it's bronchiectasis. Usually we look for this signet ring manifestation, but then there's a lot of noise within the lungs. So you see a lot of small, almost like somebody had mentioned in the chat, miliary, is this miliary TB? So it's almost like what I call a snow globe within the lung, and you see all these little particulate matter within the lung. But here, definitely, we do see this, which could be a tumor, could be an infection. But again, patient doesn't have any signs or symptoms of infection. TB comes to mind, and then we were talking about sort of pseudotumor processes. Is this a primary lung process? I guess the gastrointestinal CT was negative. We didn't see any signal anywhere else for a condition, so we have to think this is something that's primary in the lung, and then we'll elaborate on this further. Austin also mentions the right shoulder spread replace. So you're absolutely right. I didn't look up there, but you're absolutely right with this. Looking at the muscles, we have part of the muscles as well. So we have part of the pectoralis major on the left side, nothing in the muscle. But are you able to give us the reading for this, Mohan and Pranista? Thank you.
Yes, so I'm just going to read out the report. And you're right, we need multiple images, but this was chosen because I can show it to you. So the report said there are approximately 20 to 30 predominantly non-calcified nodules, mostly in the upper lobes, and you can see it in the left lung in the upper lobe, most of which appear to be new since the past CT scan, which was done around a year ago. These nodules are generally less than 6 mm in size, and there are also certain scattered granuloma in the lung bases. Now, given the size of these small nodules, we were told that these are too small to biopsy, so we decided to go with close monitoring and observation in case they decided to grow in size. So that was the report. And a follow-up 3 to 6 month CT was recommended.
So kind of interesting. What do you think, Johan, at this point? The small nodules, but they're too small. You usually, when we talk about biopsies, there's two approaches. There's transbronchial needle aspiration through the airways, putting a needle through the airway into the nodule. And then there's a percutaneous or from externally putting a needle in, but they're so small that you'll miss it. It's very hard to get something as small as that. So where do you think we would go? We kind of will have to open the door to pulmonary nodules, right? So we're in the domain of pulmonary nodules, multiple pulmonary nodules, and they're rather a small size. You're talking about millimeters. What kind of conditions? And they mentioned something like granulomas. What comes to mind when we're dealing with sort of granulomatous pulmonary nodules?
Yeah, the reading is really interesting. And
I would just like to clarify something. I'm really sorry to interrupt you, but there were multiple non-calcified nodules, 20 to 30, and then there was scattered granulomas separately in the lower lung bases. The nodules themselves weren't considered to be granulomas.
Well, I think the reading is really interesting, and two conditions that walked hand in hand are TB and HIV. And regarding these nodules, we can, as Ibrahim said in the chat, we can have TB, we can have fungal infection, and we can have a disseminated hematogenous malignancy that we have. We have a hematologic malignancy in this patient. And now we can reframe everything with our labs and with the history we have for now. So the CD4 count is at 374. The viral load is undetectable. So for me, it will be hard to lean too much toward a fungal infection as of now. The rest of the exam and the other labs didn't really push me to say, hey, the NHL is going crazy again, and the only option left is TB. So for now, I will lean more toward TB and maybe do more exam regarding tuberculosis because of the CT chest and because of all the other, I mean, the physical exam and the CBC and BMP that we have as of now.
Absolutely. I think what's interesting when you deal with pulmonary nodules, small size, the patient is a smoker, you obviously have to follow, repeat chest imaging to make sure they don't grow in size to a certain increase. I'm forgetting how much within a year. And at that point, then the patient at least also needs to have a PET CT done. And the PET will highlight any hypermetabolic sort of nodules, which could be a clue for infection slash malignancy as well. Now, what's interesting, this calcification of some of them, the body usually will calcify. It's a process where it will wall off granulomas, and it's natural. And sometimes these calcified nodules can also, mother way as a way of expelling these calcified nodules. And some of them are lymph nodes, like histoplasmosis. They may actually erode into the airway. TB can do it as well and cause these broncholiths. So I've actually had a patient that was coughing stones, and he was telling me, I'm coughing stones. I'm like, what is that? And it actually was a broncolith from histoplasmosis. You can also have this from TB as well. But I got to come back to the problem because this kind of triggered this interesting case that I had. So TB is fair game, I think. Okay, if we're in the domain of infections, TB definitely is fair game. Somebody also mentioned Kaposi's with HIV. We've had cases of that. Could this be sarcoid? The other sort of granulomatous disease I think about, sarcoidosis. There's a big outbreak out west with cocci and valley fever. So numerous people are manifesting, but you're very sick. Again, patient's not manifesting with fevers or valley fever. There's no fever with this patient. So usually very ill in the hospital, hypoxemic. The patient has absolutely no any signs or symptoms of being or having deterioration at this point. So this is a very slow growing sort of process. I would even anticipate with TB, you would have signs and symptoms, but we're not seeing that there. Other sort of fungal disorders, I know in the chat aspergillosis was mentioned. You can have mucormycosis. We've had patients with GPA, pulmonary nodules can be a manifestation of GPA. So also think about or show respect to vasculitis and maybe consider that as well. But I would look for other signals of GPA, such as the upper respiratory tract, the eyes. You could have episcleritis, kidney-associated disease as well. And then moving back to malignancies, I think Castleman's disease can also manifest, but also it's a multi-systemic condition. And again, you can have fatigue, you can have these sort of non-specific manifestations as well, and have such signal within the lung. I think probably I will land my plane at this point and turn it over to you, because there could be many different things. But I would be interested at this point, should we do a PET scan? Tumor markers, they're easy to get, but we shouldn't use them to diagnose disease. They should be to follow. All our friends in hematology oncology will tell you that could send us down a very dark rabbit hole. They could be non-specific. Tumor markers can be positive in TB and other conditions as well. So I would refrain from getting tumor markers, but I would be interested in a PET CT. And then also see what else Bernista, Mohan, and Abir have for us in the next article. Any other thoughts, Johan? Very interesting case, by the way. Mohan, Bernista, Abir, this is remarkable. I think it just exemplifies the standard at your institution and this fabulous case that you're bringing us, and so well presented. The aliquots are just amazing. I appreciate you.
Thank you so much for the high praise. And I agree with you. Even we had the thought process, we had a similar thought process that tumor markers can be useful in certain conditions, but they are not as sensitive and they are not as specific. So honestly, it won't really help us clinch a diagnosis. And we were also worried about TB at this point, and we were worried about all the other fungal infections. So we performed a culture and PCR. We performed a quantiferon gold test on the patient as well, both of which were negative. In this light, we just decided that the patient has no respiratory symptoms, he has no fever, he has no cough, no chills, no B symptoms, and the nodules were even though good in number, 20 to 30, but they were very small in size. We just decided to follow up the patient according to the Fleshner guidelines. That let's just follow up, let's do a repeat CT at 3 months, let's see what it shows, let's see if it grows in number, size, and then maybe we can go from there. And I can show you the CT that we got during the follow-up at 3 months.
Well, that would be wonderful. Thank you.
Yeah. So this is a CT scan if you want to go ahead and take a read. And then I can also point out like a magnified image that also exemplifies the finding better.
Johan, what do you think? Anything has changed in your mind from the previous one?
Well, I don't see the new CT. Okay, it's coming. Well, I mean, the only thing I can say about this reading is that, I mean, about this reading, I think the nodules are getting a bit bigger.
Yeah, do you see the nodules? If focusing on one of the some of the nodules and see it, does it look a certain configuration? Is it a nodule or is it different now? Something stands out to me. Almost like small cavities, right? There's some of the nodules have become cavitational.
I agree.
Yeah. And I don't know if that's a lymph node on the right side, but we're not seeing that configuration that we had before. But yeah, I think we have to focus in on the lung parenchyma, and those nodules are now cavity formation. And then this tree and bud formation that we're seeing here, that kind of does clue us into certain conditions. Some of the chat is mentioning maybe MAI, TB. I think Mark has mentioned that. That could be a clue as well, but it's not 100% sensitive or specific, but there's a laundry list I'm forgetting what can cause this tree and bud configuration. But two things that we initially had hypothesized about, I think we can bring it to the forefront as being fair game. Now, it's interesting, Johan, what do you think? The testing that they've done for TB, does it rule that out? Is that something we can then push to the back burner and not contemplate as causing this condition or this presentation in this patient?
Well, I personally think that the CT and the imaging will be more sensitive than the lab test that we did. So I don't think it will completely rule out TB, especially with this new imaging after 3 months.
Absolutely. I think that would be definitely a consideration. The other thing that sort of causes these small cavitations could be a endocarditis. Now, you'd mentioned, hey, every case of endocarditis that I've seen is patients always very toxic, septic. They have bloodstream bacteremia, so they're very ill. But you can get sort of this subacute chronic endocarditis where the patient's sort of feeling fatigued and just not feeling themselves. And like you'd mentioned earlier on, inflammation, it is a highly inflammatory state and you can get weight loss. So it's something to think about in a patient like this as well. And something unlikely, I would say, but I would keep it in our bucket list of possible differentials. So should we move on to the next aliquot? At this stage, we've done imaging. We thought about PET. How about bringing pulmonary medicine in? Bronchoscopy helpful, BAL helpful at this point. I'm not sure which way you went with this case.
Yeah, I agree with your assessment. That's what we thought, that this is high time we involve pulmonology on board as well. So we sent the patient to a pulmonologist, and he decided to do a guided bronchial lavage on the patient because the nodules were growing in size, the nodules were increasing in number, and there were new onset cavities in the nodule as well. So here we are also worried about malignancy, but maybe some infectious process is going on that we might be missing out on. Even though the patient has normal CD4 count, undetected viral load, no symptoms. But sometimes these conditions can present silently. So we did a BAL on the patient. It showed no growth of any fungal elements, no growth of any bacterial elements, no malignant cells. We even did the testing on BAL for TB. It showed no TB. We did testing for Aspergillus, the PCP pneumonia. We did histoplasma testing, blastomycosis testing. We did cryptococcal testing, and all of them were negative.
Wow. Johan, what do you think at this point? I think we've pretty much drained our brains of all the potential causes of such a presentation. What do you think at this stage?
Wow. I mean, first I want to thank this amazing residency program, and this is a really, really humbling case. So let's go over the bronchoalveolar lavage. So the fact that TB and all the other and all these other organisms were negative is kind of surprising to me. And I just have to reframe and talk about the buckets we had at the beginning. We're able to rule out hematologic malignancies. I mean, not rule it out, but put it down on the differential list. TB and infection was first. Now infection is completely off, and the third point will be maybe an unknown syndrome that we didn't think about. So I will now lean more toward a syndrome. I mean, if I was taking care of this patient, I will go back to the literature and try to connect the dots with maybe a syndrome I don't really know. That's why I will have done instinctively. But as of now, it's really difficult for me to make any progress.
Yeah, I think at this point, we may have to reflect back. We've had numerous cases where we've considered the cause, so the diagnosis is within the discussion, but the testing presented hasn't really revealed the diagnosis. So you have to start considering, is the testing valid or not? Does the test give us enough evidence to rule out this condition? So as you all know, tests can have a lot of false negatives. Testing, the conditions within which we do tests could also not be optimal. So you have to consider about repeating the test. Either you can do this, patient stable, of course, they have this condition, bring the patient back, repeat the testing like you did the imaging. Number two, if your suspicion is high enough to then consider a alternate modality of testing or repeat the testing, could the second repeat of the test reveal the diagnosis? Or consider another diagnosis instead if you feel that your test is powerful enough to have ruled out that condition. So as you all know, that TB has many different ways of being diagnosed, and it's a very slippery condition where we've had cases where it's not apparent with all our quantiferon, AFBs, and so on. So I have to start considering, like, should we push forward with more testing for TB? Somebody in the chat mentioned that TB can be very difficult with BAL, and we may have to consider maybe even if there is any biopsiable. I don't know that right side, if that is a lymph node or is that associated with it, is that something that a transbronchial needle aspiration could help with? But I would send this back to Bernista, Mohan, and Abir to see what they did with this patient.
Yeah, I agree. And even we did the culture and PCR for TB as well, which was negative apart from the quantiferin and gold. So at this point, we also started thinking about all the zebras and we started involving autoimmune into our differential because even rheumatoid, SLE, Sjogren's, there is very rare possibility that this all can also present with nodules as well. So we decided to repeat a CT scan at 3 months, but in the meantime, we also worked the patient up for all the autoimmune conditions. We did anti-citrulline peptide, we did the rheumatoid factor, both of them were negative. We did the ANA panel, the entire panel was negative. All the anti-centromere, anti-double strand DNA were negative. Sjogren's A and Sjogren's B were negative. We also did something called a biomarker 3 panel, which tests for anti-synthetase syndrome. It tests for dermatomyositis and polymyositis, basically the connective tissue disorders. Again, the entire panel was negative. And in the meantime, when we did a follow-up CT on the patient, we saw that the nodules were again increasing in size. There were appearance of more cavitating nodules, and there was some appearance of emphysema on the CT scan.
So I really like that. Oh, sorry, go ahead.
No, sorry, it's because like we are running out of time.
Oh.
This is the last aliquot, like before the diagnosis? Ah, okay, perfect.
Yeah, I apologize. The discussion has been, it's a very complex case and I must say, very educational case. If you look at the journey through this case from weight loss to really nothing much in the exam, the labs, we talked about HIV, we talked about non-Hodgkin's lymphoma. Now we talked about respiratory conditions and nodules that now cavitate. And then I'd like the workup pivoting to autoimmune conditions like we earlier had hypothesized. Rheumatoid arthritis, definitely you can have cavitating nodules. GPA is definitely high in the running and can manifest with cavitating nodules. Malignancies, the patient also does smoke, so bronchogenic carcinoma can cavitate. All the nodules like this, I don't feel like you're going to have small nodules like this, but metastasis can, if you have diffuse metastasis, which can be hematologically spread and can cavitate like this. So you have to think about this. But again, TB, fungal, staph, and so on can also cause cavitation, especially I've had patients with septic emboli from endocarditis. You have to start thinking about. Anything else comes to mind, Johan, before we move on to the next aliquot?
Well, I think the only thing we can do, I mean, I will just think about what will be the next step. So after I think this is the third CT, and the nodules are getting bigger. So is it time to biopsy them? So this will be my the biggest question for me. What should we do now? So I think it might be time to biopsy them. What do you think, Dr. Ravi?
I think so. Yeah, definitely. If we are able to biopsy, and I agree with Rich in the chat, maybe an echo to see if there's a chronic endocarditis that also may be at play. Or I even had a patient with myxoma that was embolizing into the lungs, and that could be something along those lines we have to consider. Over to you, Pernice.
Yeah, I agree with your reasoning because we ended up doing all the tests. Everything was negative. We decided it was time to go ahead and do a biopsy. So we did a VATS guided wet biopsy of the patient. And I can show you the pathology images if you want.
Oh, that would be wonderful. Thank you.
Yeah, so here are the pathology images for the patient.
So at this stage, could you read?
Yeah.
I'm not able to read this as many years from
Yeah.
histopathology, but
Yeah, I would just read the histopathology report that we got from our pathology lab. So the biopsy revealed conspicuous nodules with a stellate configuration in a bronchiolocentric distribution. Many of the nodules were fibrotic and acellular, associated with parasitracheal emphysema, and a distinct pattern of airspace enlargement seen in certain interstitial lung disease. But the cellular nodules displayed a mixed infiltrate of eosinophils and histiocyte-like cells, creating a vaguely granulomatous appearance, very typical of Langerhans cell histiocytosis.
wow. What do you think, Johan? Definitely along the lines of autoimmune conditions, hematological conditions, and then we didn't really mention Langerhans cell histiocytosis, but definitely is one of those conglomerate of conditions that can cause something like this.
Yes, I agree. What an amazing case. Thank you so much. This is so humbling. And thank you, Dr. Ravi, for starting with really good buckets and guiding me through the case. I've learned so much on this case, from the weight loss to HIV to the dissecting, the imaging, and the labs as well. And I'll definitely do more readings on this condition. We on TB solvers, we have so many rare conditions, and it's one of them, and I will definitely do more reading on it.
And same, Johan, I really appreciate you taking the forefront of discussing this case. I'm just here to back up, but you've done a wonderful job. Very complex, very high level case. And I think this is just so amazing to go through this, because I've even learned a lot, because once in a while you will have a case like this and you will have to then go to the limits of your experience, and you may not even have the experience, but knowledge to try and figure out what do I do next, because all the testing was pretty much negative. It was until we did the biopsy, the diagnosis was revealed. So very complex and difficult case, but I'm very happy to be here co-piloting the discussion with you, and really appreciate you, Pranista, Mohan, Kashish, Vivek, Beer, for bringing your program here and doing such a wonderful job and giving an insight into the sort of patient care that you deliver there at your institution. Over to you, Deborah and Yas.
I think, Vivek, do you want to share something?
Yeah, I mean, I had some notes made about pulmonary Langerhans cell histiocytosis, but I think for time restraints, I'll keep it short. But I think the lack of respiratory symptoms really threw us all off. Like, we were so focused on fatigue, weight loss, and like they say that about 60 to 70% or so patients like usually present with respiratory symptoms like cough, dyspnea, but this patient did not have any of that. I think that is why we sort of looked over it, or maybe did not give it enough priority. So this is essentially interstitial lung disease, or what we call diffuse parenchymal lung disease. So I think it's also important to keep those differentials in mind, and especially given his smoking history, if you put the two things together, you go over the different patterns. And this patient had nodulocystic, sort of picture, and with a predilection for upper lobe and the middle lobe. I think someone in the chat mentioned Langerhans cell histiocytosis at one point. So, they were on it. So, but yeah, it's a very interesting case. It makes you work. You have to sort of go through the whole differential. But yeah, in this patient, so most of the patients, they improve with just smoking cessation, surprisingly enough. About 60% of them do improve with just smoking cessation. We reiterated the importance of quitting smoking and everything, and the patient did quite well. And so with just the smoking cessation at like 3-month point, his fatigue had improved and his weight has stabilized, and he was starting to gain some. So because of that, we did not go with steroids, which is another line of treatment, or some chemotherapies like cytarabine. But in advanced cases is only when you think about lung transplantation. But with him, with just smoking cessation, he actually showed improvement, and we are following him up. and we are monitoring with CT scan. High resolution CT is what would be the best, and I think we will follow him up with just that. So that's will wrap up the case, I guess. He did also have a pathogenic mutation. I don't want to forget that. So the most common mutation that you look for is the BRAF V600, and the slightly less common mutation is the MAP kinase 2K1 mutation, which this patient had. So there's that.
Wow, amazing. Thank you so much for this amazing case and these teaching points. We are super happy to learn with you all. So we can talk a little bit about the program, and if you all want to share, Beer, if you want to share how is your intern year, how are you feeling?
Okay, I can start. Honestly, like before starting residency as other applicant, I was looking like for supportive, open-minded environment where we can learn and grow as a physician or even like in a personal life. And after like I start my residency, I found it. Like I'm glad like for being part of this community. The people here, everyone like is welcoming, everyone want to help. Whenever like you have a concerns or like any comments, like our programs, like including resident, faculty, they take it seriously. And I'm always like have a support team. Whenever like I have a thing, I have some people to ask. Yeah, so I think my people, like, yeah, the people here, which make it like, yeah, more easy.
Vivek, do you want to share?
Yeah. So we are a community-based program in Shreveport, Louisiana. But we are quite a large health system. We have like 4 campuses, and the main campus, like the hospital, has about 400 something beds. You know, we have 2 ICUs, we have a cancer center, we have a heart institute, we even have a transplant center, the only one in the this area. We do lung, pancreas, kidney transplant. So we are a big program, and we have about 30 residents in the internal medicine program, but we also have a general surgery residency and a psychiatry residency, and we have plans for fellowships in the near future. Probably starting with PalmCred, which is one of our stronger specialties. And one of our critical care attendings also joined the Zoom meeting today. I think he's there somewhere. But yeah, so we have fellowships coming in the pipeline pretty soon. And we get medical students from like 3 nearby DO schools. But yeah, I mean, I think the most important thing is how supportive the program is. We are, relatively young program, but everyone knows everyone here. They're very supportive, which is why, I think our program director might also join the Zoom meeting. And so we have like 2 faculty, supporting us here. We have, a lot of like perks that comes with the residency program. And this year we had the first graduating class, and I think a real testament to the success of the program would be our match rate. Like we had 7 people match into all the specialties. I matched into endocrine at NIH, so I think we have a great class of residents.
Oh, congratulations.
Thank you.
And Moham, do you want to share with us a little bit about the program?
Hey, yeah, I would pretty much add to what Abir and Vivek said, that this is a very supportive program. They support us for our conferences, they support in research, they support us with educational stipends in case we want to get all the resources. And the biggest perk I would say is that we get free food in cafeteria as residents, and helps me. I don't cook much, and it saves a lot on groceries. It saves a lot on my efforts in cooking. So I would say it's a really good program. We get a very supportive environment. We get good seniors like Vivek who guides us throughout. And if there is any concern or any problem that we might face, the program is very open. the chief residents are very open. We can always approach them for even any minor inconvenience we face, we can anyway approach them. And we are also very IMG friendly program. We have a diverse population, from South Asia, Middle East, Egypt, and the United States as well.
And personally, just to add one last thing, my favorite part is just the people over here, the faculty as well as the residents. Everyone's great at what they do. They expect high things from us. They set a high standard, and it's a great place to learn, all in all. So that's it.
Amazing. Thank you so much for sharing with us the highlights about the program. We are really happy with the session, and we passed a little bit of time, but was really good to be with all today. Please feel free to come back and present more cases. It would be a pleasure for us to receive you all here. And thank you, Abir, for organizing and bringing your program. You make us really happy. So, and thank you, Ravi, Johan, for discussing this great case. And yeah, I hope to see you all during the week or tomorrow. Bye-bye.
Look forward to it. Thank you so much.
Really enjoyed the discussion. Thank you for having us.
Thank you.
Thank you.
Thank you so much. Bye.